Good evening and welcome. Thank you so much for joining us tonight for the webinar, Identifying and Supporting Anxiety and OCD in the Classroom, presented by Dr. Devora Scher. My name is Katie Delaney. I am the Family and Medical Outreach Coordinator for the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your facilitator for this evening. Before I introduce Dr. Scher, we have some housekeeping notes. All participants are muted. At the end of this presentation, we will have a Q&A. Please list any questions you may have in the question box at the bottom of your screen and click send. If you have questions after tonight's session, you can post them on the Wednesday webinar blog, which can be accessed from our homepage at www.njcts.org under the headings Programs. This blog will be monitored for the next 7 days. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendations or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now it is my pleasure to introduce our speaker for this evening, Dr. Devora Scher. Dr. Scher is a licensed psychologist at Central Therapy. She specializes in the treatment of anxiety, obsessive compulsive disorder, TIC, and body-focused repetitive behavior disorders. In addition to her current work, Dr. Scher is also an adjunct professor at Touro College. Dr. Scher, we are so happy to have you here tonight. The floor is all yours.
Thank you so much, Katie, and thank you everyone for joining tonight. It's really my honor to be with NJCTS again tonight. And for those of you, I know Katie just said, but I want to amplify that NJCTS really provides incredibly worthwhile resources to individuals, families, schools, and probably much more. And if you're not familiar with them, definitely I encourage you to check out their website. And tonight we'll be talking a lot about the school setting and how anxiety and OCD are manifested in the classroom. And for those of you who may have been at the New Jersey Educational Association conference, there might be quite a bit of overlap. I do have this challenge though, because that was a 90-minute presentation, and tonight we'll be trying to do this in 45 to 50 so that we'll be able to, I'll be able to answer some questions, and I'm fine with going over a little if there are questions. So we'll start off by identifying common manifestations of anxiety and OCD symptoms in the classroom. We'll really just touch upon empirically supported treatment protocols, because I want to be able to focus on practical skills in the classroom to support students with anxiety and OCD impairment. There are so many themes, so many flavors to anxiety, and while many of you, well, if you're not a mental health professional, you don't really need to know the diagnostic criteria. I won't even really be focusing so much on the diagnostic criteria, but I do want to focus on the different themes to anxiety, because by understanding the specific fears a child has, we're in a much better position to support them. I really want to emphasize the adaptive elements to anxiety. Anxiety is great. Anxiety is really helpful many times. And the goal of any anxiety and OCD treatment is not to remove anxiety or obsessive thoughts. It's really only indicated if there is impairment associated with the anxiety or OCD, and if there's value to addressing it, if there's a need, essentially. Unfortunately, anxiety disorders are quite prevalent. There are recent research I saw, I think this was the Kasdan 2018 article, was showing approximately 20 to 35% of adolescents between 13 and 19 years old experiencing an anxiety disorder. And unfortunately, we know that most people who, only approximately a third of people with a diagnosable mental health condition are receiving appropriate treatment. There are so many reasons for this. There are unfortunately quite a number of treatment barriers, including those related to finance, those related to qualified providers, understanding a lot due to lack of knowledge in terms of symptoms and which treatment to pursue. And I know COVID definitely has opened up more remote therapy, but there are still transportation barriers and things like that. It follows that there are so many advantages of the school setting. My dissertation actually really focused on the school setting and mental health treatment in the school setting, because I mean, children are in their natural setting. There are so many opportunities to intervene, to notice what's going on, and anxiety and OCD are so much, I mean, they're really internal disorders. And oftentimes the child, especially if they're young, don't even necessarily understand what's happening for them. So oftentimes anxiety and OCD go unnoticed, and early intervention is so critical. So let's start talking about the different forms of anxiety. We'll start with generalized anxiety disorder, which can be analogous to a whack-a-mole game or activity, where essentially what happens is there's a worry pops up, and we do whatever we can to reduce that worry, but then another one just comes right back. And that's really what GAD is about, where the worry is on everyday concerns. So traffic, finances, studying for a test, a lot of daily normal quote unquote concerns, but the content of the worry just keeps on changing. It's interchangeable. And this would have to result in impairment, like most mental health disorders, last at least 6 months. And in the classroom, what we might be seeing is, in addition to the worrying, a lot of reassurance seeking, difficulty concentrating or completing work, self-criticism, and avoidance, which is the hallmark of most anxiety disorders. Typically with all anxiety disorders and OCD, really, we're looking at an overestimation of risk and an underestimation of coping abilities. So let's talk about social anxiety. Social anxiety is, I think I read a 2022 article showing that it's the third most prevalent mental health disorder. Before that came substance abuse and depression. And social anxiety disorder, well, I could have said about the generalized anxiety, going back a second, it's really quite rare, especially in 4 to 11-year-olds. We're seeing like less than 0.4%. Social anxiety disorder, we're looking at least 10% of the population. And what this is about is excessive and persistent fear of evaluation, fear of doing or saying something that will make a person look embarrassing, will make a person look bad, and the fear of unwanted, they don't want to be the center of attention. And it's understandable that the person is going to feel an urge to avoid these situations where the evaluation might occur. So in elementary school, these children might be hiding in the bathroom, they might be crying, they might be complaining of stomach aches or other physical complaints. And usually for younger folks, it's more difficult to identify the feared outcome. And by the time they reach middle school, sometimes they're able to express what's going on. Sometimes they pretend nothing is wrong. They're trying to find excuses, trying to avoid with excuses. I think there's a missing word there. And by high school, they might not want to talk about it, but they're likely much more insightful in terms of the rationale for why they're feeling anxious before a public speech or even before a trip or going to the lunchroom. And oftentimes there's avoidance, they're refusing to comply with demands with regard to approaching that activity. Panic disorder, oftentimes people say that they're having a panic attack, and I think it's important for us to talk about what is a panic attack, what isn't a panic attack. A panic attack usually peaks at around 10 minutes, and it's a period of intense physiological anxiety. Usually, I think it needs 4 physiological symptoms like rapid heartbeat, dizziness, trembling, hyperventilation, things like that. And oftentimes there's a cognitive component here to the effect of, let's say, fear of going crazy, fear of dying, their body is out of control, and they're oftentimes really uncertain whether or not they're having a heart attack. And we know if it is a panic attack, it will not result in a heart attack, but the person is oftentimes frightened by their bodily symptoms. So it's also uncommon in elementary school students, but if it does happen, the way it would manifest is usually less of those cognitive concerns, usually not as afraid of the death, just really uncomfortable during those approximate 10 minutes. Usually the child becomes aware of the triggers, then it's understandable again that they'll try to quickly avoid the triggers. By the time if the child's in middle school during these panic attacks, well, that was pretty strong. Middle schoolers are more likely to be fearful of death. They're also going to quickly identify and avoid the triggers. And high schoolers, panic attacks would be more common in this population. They're less likely to think that they will die, but they are oftentimes thinking that they're going crazy, that this is a huge catastrophe. And what we know is that if it's untreated, it's much more difficult to face fears in the future. Obsessive compulsive disorder I want to talk about next, and this is something that I probably see 80% of my caseload are people experiencing obsessive compulsive disorder. So I hope I won't talk about this for too long, and I mean, I'm happy to, but I want to be mindful of the time. Obsessive compulsive disorder is actually no longer an anxiety. It's no longer characterized as an anxiety disorder because of the research supporting so many other negative affects, so many other experiences aside from fear relating to the obsessive compulsive cycle. So for example, we're finding that guilt, that shame, that disgust are also very much prevalent, and it's really not exclusively an anxiety disorder. So what OCD is about is it's much more than hand washing, it's much more than checking locks. What it is about, though, it's about unwanted thoughts, images, or impulses that are oftentimes extremely, I mean, they're distressing, they're terrifying, and the person doesn't like these thoughts, images, or impulses, and they're trying to get rid of it because it's so uncomfortable. And it's important to acknowledge that I think the studies are showing like 98% of people have intrusive thoughts. 98% of people, or something like 98, over 95%, have these obsessions, and whoever I hear citing these studies say something like, the other people are liars. We all have, or most of us have obsessions. Obsessions are normal. And what marks a person, what differentiates a person with OCD and a person without is the person's reaction to the obsessions. So an example of an obsession that someone might have without having OCD is many people have this thought like, oh no, if I would have pressed the gas instead of the brake at the stop sign, I could have killed 3 people. That's a really scary thought. Many people, though, are not bothered by that, whether because so many reasons, but they're trust themselves enough that they're willing to take the risk and drive either way. Someone with OCD might try to avoid driving because the thought and the fact that that thought entered the person's mind carries meaning to it. It feels almost like the possibility of doing that harm is so much more likely, perhaps. And if the person is driving, they're more, in order to meet criteria for OCD, they need to engage in compulsions or rituals. So in that example, the person might be checking excessively. The person might be only driving with a companion to serve as some form of reassurance, or mentally reviewing to themselves, the likelihood or just the fact that they've never gotten into a car accident before. So it could really be it's any repetitive behavior or mental act that's aimed at reducing the distress or preventing that dreaded event. And this is an easy formula that I like. If I do or don't do this compulsion, if I do or don't check, then it's much more likely for my fear to occur. So I need to check in order for me to feel more comfortable with that fear. And the heart of all OCD, and we'll talk about some common obsessions and compulsions, is fear of uncertainty. There's, I guess, intolerance with doubt. So obsessions are oftentimes, a person usually has more than one theme of OCD, more than one theme of obsessions. They oftentimes latch onto a person's values, what's meaningful to a person. And they're really all, though, about, and part of the treatment is disengaging from the content, because it's not so much about the content, whether the content is related to contamination, fear of germs, fear of illness, fear of just sticky substances or things like that, or whether it's harm related. Harm related OCD could manifest itself in some form of fear of harming myself. So it's going to be much harder for me to, I don't want to touch knives because I don't trust myself. And again, there's this doubt over here of I don't know whether or not I'm going to hurt myself. And I'm not willing to take the risk, or I can only take the risk if I engage in these compulsions, if I have someone next to me, if I seek reassurance, if I clean excessively, wash, etc., etc. So excessive doubt, I'm just going through, excessive doubt is really all of OCD. But in this case, I could think of so many examples, committing to a school schedule, committing to a certain course, or picking an elective. So obsession, it could be related to perfectionism, not necessarily, but I don't know. I might be making the wrong choice, or I don't have all the information that I need. And a compulsion with that might be mental, or it might be asking for a lot of advice, trying to receive excessive information, delaying, hesitation, avoiding could happen in that case. Moral concerns are not necessarily related to religion, but of course it can. OCD can latch onto religion, but an example of a moral concern might be, I don't know, so moral is about excessive concern with right or wrong, or scrupulosity. So I might have touched that. I might have, when I opened my cards, or I might have scratched or dented the other car. So I'm going to confess, I'm going to write a note just to be sure, because I can't handle not knowing whether or not I did something right or wrong, or in that case, wrong. Selective mutism is something very close to my heart. Perhaps it's something gratifying that I find gratifying to treat, likely because I met criteria for selective mutism as a kindergarten first grader and probably half of my second grade school year. And because thankfully my daughter, and yes, it's genetic, my daughter is recovering from selective mutism. So it's something I think about a lot, and find that there are oftentimes misconceptions, regarding many mental health disorders, selective mutism in particular. Let's first talk about selective mutism, what selective mutism is. So it's characterized by consistent failure to speak in social situations when speaking is expected, despite being able to speak in other situations. So typically, and let's say in the case of my daughter, she was able to freely speak in her home setting, in many outdoor settings, but particular indoor settings, namely schools and friends' houses and other unfamiliar houses, there was consistent failure to speak. And some people, oftentimes, and this is probably my pet peeve, some people almost say things like, oh, she's just shy. And it's hard to know exactly what the person means without clarifying, but upon clarification, usually what a person is trying to almost reassure me by it's just shy is, oh, it's not a problem, it doesn't need treatment, or maybe this is just my daughter, or whoever this is personality. And I certainly agree there are some people that are quieter. There are some advantages. There are advantages to quietness, and selective mutism would only be diagnosed if there's impairment and consistent failure to speak in certain situations with the ability and to speak in others. So if a person is getting lost and unable to say their name to someone, it's almost like, it's not like there's an on and off switch. Oh, right now there's a huge need, so I'm able to speak suddenly. When my daughter needs the bathroom and is unable to ask, those are examples of impairment. And I wouldn't necessarily, maybe we can call this shy, but I think it's more helpful to diagnose it because it is so treatable. And what we do find is that typically the passage of time alone without intervention does not adequately treat selective mutism. It doesn't treat selective mutism. We are unable to diagnose that if it's the first month of a school, because that's more typical or expected for the person not to talk or be hesitant to speak. And it's of course nothing to, it's not related to comfort or knowledge of the spoken language. And it's also, we would need to rule out a communications disorder for that diagnosis. Perfectionism is actually something that I spoke about, I think, last April with NJCTS, and the recording is available if you're interested in more. With regard to perfectionism, it is not yet a diagnosis. Whether or not it should be, I have a feeling it may be. Sometimes perfectionism is correlated with OCD, but not always. And I think it's oftentimes manifested in school settings, so I wanted to talk briefly about it. Perfectionism is about, is I guess, this personality disposition when a person might be striving for flawlessness and setting exceedingly high standards for themselves. So oftentimes they're motivated by the fear of the negative emotions. So for example, they're playing the game so that they don't lose. They're studying for the test with almost like the only motivator, usually it's one of the only motivators to avoid failing. The fear of the failure, the fear of the losing is so overwhelming that oftentimes that's the motivator, and they're going to judge themselves almost exclusively on the outcome. And this oftentimes is manifested so many different ways in a school setting. I'm not sure if I'll read all the examples, but one of the key hallmarks of perfectionistic behavior is procrastination and avoidance. And what we find is, I think the reason, when we think about how overwhelming the person's standards are for themselves, it makes sense that they put so much pressure on themselves. It makes so much sense that they would avoid or procrastinate, because their goals are essentially unattainable, or they feel that their goals are unattainable. Oftentimes, despite positive feedback, despite your commenting about the person's job well done, they're disqualifying their performance and really focusing on the mistakes here. Oftentimes with perfectionism, there's a lot of reassurance asking, is this correct? Is this right? What would you do? And there could be erasing and rewriting. And I think it's important to mention that perfectionism is not necessarily the same in every setting. So the person's behavior, first of all, might not look perfectionist. Oftentimes a parent might say, like, you have to see their room. They're not struggling with perfectionism. Their room is a mess. First of all, it doesn't necessarily have to apply equally in all settings. But another important point is sometimes, like I said, with avoidance and the procrastination, the fear of maintaining a perfect room, the fear of maintaining a certain standard is so overwhelming that all or nothing thinking comes in, and it feels too difficult to try. I'll let you read the rest of the examples another time, or to yourself, because I want to move on. Perfectionist concerns can correlate with both psychiatric and medical conditions. So it's important to really address. And at this point, I want you to take a moment to think about some anxiety and OCD behaviors you've observed in the classroom, or if you're not school personnel, what anxiety and OCD behaviors you've observed in a child that you have close contact with. Oftentimes, these are an overview of red flags in a school setting in particular, because that's what we're focusing on tonight. So frequent school nurse or bathroom visits, excessive reassurance sought, requests for repetition or additional excessive clarification, refusal to touch others, books or belongings, compulsive apologizing, explaining or confessing, checking and avoidant behaviors, and seeking help with communication when it's not age appropriate. So at this point, I want you to consider, I know already it's probably pretty dense, and I want you to consider your role and its limits. I mean, while I would love to be in the school or really just like intervening in real time, that's not my role. And similarly, if you're a school personnel, it's really not your role to treat it. But what I'm hoping you'll be able to do after tonight is better understand student experiences, support students as the anxiety is impacting their academic performance, share observations, and consult and refer as needed. So as we continue, well, I guess part 2 is the part that I'll review probably a little more quickly even, and that's because I don't expect this presentation is more geared for school personnel. So I want you to have some familiarity with the treatment approach, but we'll focus on the practical skills tonight. So I want to really understand with you how anxiety works and how it's maintained. So typically when a person is in a triggering situation, let's use the example of a roller coaster. We the person's online, the person's anxiety starts to intensify. It's climbing. And I don't know if you see my mouse. I don't think you do. So you'll follow along here. So the anxiety is climbing, it's rising. And at a certain point, it feels like it can't get much higher. And it's at that point where the person's going to have to make a decision. Do I have the energy and courage to proceed and ride that roller coaster? Or does it feel like too much for me to tolerate right now? And essentially that question is, do I approach my feared activity or do I avoid my feared activity? And let's say for purposes of this example, I don't have the emotional energy I need. I feel so overwhelmed. I feel so sick. My body is hurting in every which way. And I'm going to turn around on the roller coaster ride line. And what happens when I turn around are a few things. The first thing that happens, the first thing I learn is I feel better when I turn around. Leaving the line helps my awful anxiety get much better. And it got much better quickly. I want you to notice that like sharp decline here. It's almost like a straight line down. The anxiety quickly drops when avoidance happens. So of course, the next time I'm in that activity, I'm going to learn that, or even if I'm at a similar activity, I learned how to handle my anxiety, sort of. I learned that when my anxiety feels like it's at that high point, I'm going to avoid or escape, and I'm going to feel better. And what I really learned is, unfortunately, that the only reason why I'm okay is because I avoided. Or I'll take it one step further. Rituals or compulsions work the same way. What I'm going to learn is the only reason why my anxiety got better is because my teacher said that my answer was correct, and I was feeling such excessive doubt with regard to whether or not I was on the right track, whether or not I was going to fail this exam. So I just got some reassurance, and that reassurance made my anxiety go down. So I only was okay because of that. And this is so incredibly reinforcing because the feeling is good in this distressing incident. So it's extremely understandable why avoidance is the choice. And the problem, of course, is that the person fails to learn that anxiety is tangible, that they can do hard things, that they can tolerate just intense emotions, that anxiety won't last forever, because instead what I learned was that the reason why it went away was because I avoided. And I want to really acknowledge, it doesn't feel great if I would have approached that roller coaster. In all likelihood, if I have anxiety about roller coasters, the line does not go down right away. It's a much more gradual process. You'll see we call this riding the wave, which is actually our camp name for this summer for anxiety and OCD. It's riding the wave because we're learning how to ride that real intense discomfort. So oftentimes as parents, as teachers, even as psychologists or therapists, it's easy to contribute to avoidance. It's easy to help that person avoid because we want to reduce the child's distress. It is so hard to see my child's in distress. And I mentioned she was struggling with selective mutism. And it's so much easier to answer that question for her, for example, when she's avoiding a question. And oftentimes parents or teachers or anyone really also might believe that the child will fail or the child might even get hurt if we don't help, whether it's failing an exam or failing another activity, failing a social activity. Sometimes we worry that the child will become disruptive, and oftentimes we're just really feeling uncomfortable and we want to reduce our own frustration, guilt, and or anxiety. It is so normal. Research again shows that over 90% of parents and teachers do engage in avoidance behaviors. The fancy word for that we use in the anxiety world is accommodations when we help with avoidance. These are the most common accommodations that we find, where we might provide excessive reassurance, we might allow extra time due to checking, excusing children from assignments, opening doors, or holding back from certain topics or using particular words because of the child's anxiety. So what we also found in the research, I'll go back a second, is that most parents know that accommodations or helping with avoidance isn't ideal, but most parents in the studies reported that they just don't know how to handle the child's anxiety, that they don't have a great alternative. And tonight we'll focus much more on the alternative that we'll do. So in actual treatment, meaning not in I guess like a parent or a teacher supportive moment, which is what the part 3 is about. In treatment, we're going to focus a lot on psychoeducation, which is what we're doing now, and rating anxiety. And based on the ratings, we're going to craft exposure exercises with response prevention. Essentially, we believe, and the research supports, that experience is the greatest teacher. Just like you're not going to be able to convince an alcoholic that about the downsides of drinking, and that on its own should work with their abstinence. Similarly, we're really going to work behaviorally. It's a behavioral treatment. We're going to craft experiments based on the specific fears, so that the child can learn that they can handle uncomfortable things, they can do hard things without relying on the rituals, which is the response prevention piece. So we're going to remove the compulsions while approaching manageable. We're going to work gradually and while we're working, but we are going to approach these activities. This is a very similar diagram to the riding the wave one, and I'll use a different example while we go through this. So this is more OCD focused. So let's say a person has more of the perfectionistic type of OCD, and the trigger is taking a test or doing a homework assignment. And their obsession is they're obsessing over the accuracy. How do I know I got it right? Again, OCD is all about how do I know? So I need to know. I have this urgent need to figure out whether I got this question right. Their mind is stuck there. It's causing anxiety or distress. Then there's going to be this urge to neutralize the obsession, and that's going to, in this case, result in, let's say, reassurance seeking. So I'm at home, I'm going to ask my mom to edit this work or review this problem, make sure that I got it right. I'm at school, and even if I'm taking a test, I'm going to figure out any way to try to get that answer out of the teacher, or try to base something on whether or not they might even tell me the answer if I'm on the right track or if I got it right. But sometimes even just I'll try to figure out based on their facial expression. And all of these compulsions are intended to get as far away from the feared outcome occurring. So in this case, the feared outcome might be fear of failure. So I want to make sure, and it's so understandable, and there's a lot of room for validation here. I know how hard this is. Of course you want to get this right. And the problem is, test taking for these individuals might become extremely difficult, because these compulsions are essentially teaching that child that the only reason why you felt better was because you got that reassurance. And that's how OCD is reinforced in this case. So we'll talk about how to respond to those reassurance-seeking behaviors soon. Mindfulness is actually not taught in the midst of an exposure practice. So in the midst of a distressing moment, we don't necessarily, and I'm speaking carefully because it really, some of this does depend, but ideally we don't want to prompt the use of mindfulness skills. Mindfulness skills isn't necessarily about just like sitting quietly and thinking. It's really about, there are two types of mindfulness, really being attentive to one's thoughts, emotions, physical sensations, or in the attentional control work, we're working on staying focused on one thing at a time. And there's a lot of value to this, and I'll talk later about why we don't want to do it in the middle of an exposure. But the bottom line is, obsessions and anxieties are distressing, and oftentimes a person wants to try not to think about that thought or feeling. But how well does that work when we try not to think about a thought or a feeling? You might be familiar with the pink elephant example, where I tell you, don't think about that pink elephant. And there's a 5-minute exercise there where it's even harder. But of course, it's likely that the pink elephant will pop up, even though you probably don't think about the pink elephant all day. And similarly, the beach ball metaphor, where if you try to get that beach ball under the water, not only will it reemerge, but it'll actually make quite a big splash. It'll actually be more prominent. So just don't think about that. It doesn't usually work with anxiety. Oh, well, I said I would talk briefly about, so the reason why we don't usually encourage mindfulness in the middle of an exposure exercise is because we don't want the person to think that the only reason why you handled that was because you were extremely mindful. We do want them to be mindful, but we have to be cautious about any type of coping skill, like deep breathing, like even, and there might be some questions on this at Q&A, even things like a benzodiazepine like Klonopin or a quick acting anxiety pill, we're really not going to want to use in the middle of an exposure exercise. It undermines the exposure and teaches the person that the only reason why they were able to engage in that activity was because their mood, because their breathing was a certain way. And we want them to be able to handle hard things, even if their body is a little anxious or very anxious. Cognitive restructuring, we use more for social anxiety than OCD and other anxieties, and that's really about being mindful, noticing the helpfulness of particular thoughts, and developing coping thoughts as needed. And now we're at part 3. So part 3, we're going to talk about practical skills to support children with anxiety and or OCD in school. So this acronym was taught to me by Dr. Alana Kagan at Johns Hopkins. She's great. And she developed this lemur model as a way to help parents, help teachers respond when their child is expressing particular anxiety. So I'm actually gonna, for the sake of time, I'll review the model again after, but we'll jump into the L over here, which is labeling. One of the most important things is to resist the urge to problem solve immediately, and instead focus on labeling. Express with curiosity, non-judgmental interest, try to understand as best as you can the child's belief, the child's concerns, the child's exact fears, kind of like what we did in the first phase. Are we talking about a fear of harm? Are we talking about fear of being in the center of attention? Don't run away from talking about the details. In fact, the more we can approach the details, the more we're really able to help them and help them identify their action urges, what they feel like doing. And the goal, of course, will be to resist action urges if they're unhelpful. So we're going to do a lot of expressing interest, where if the child's older, we might, and even if they're younger, like identifying the triggers, helping them understand when they're in certain situations, they're more vulnerable to these thoughts. So that way they can almost be prepared, expect it. Oh, that thought might come up when you're at that stop sign. That thought might come up when you're taking the test, and observing past helpful and unhelpful responses to the triggers. And this might be more of a therapist role. You don't have to. It could be helpful though. The next part is probably one of the most dense skills here and one of the most important. And that's about expressing empathy, expressing confidence, expressing compassion without rushing to accommodate. And remember, accommodate means without rushing to help them avoid, and without rushing to immediately minimize the child's distress. So on this note, I'm going to go on a little tangent to talk briefly about anxious parenting. Dr. Ellie Leibowitz, who's the director of the SPACE program at Child Study Center at Yale, talks a lot in his book, it's a great book, about anxious parenting and the 2 common pitfalls that emerge. And those relate to the demanding nature, where oftentimes parents might find themselves, teachers, also therapists, almost encouraging the demanding, essentially, the child approach certain activities by saying, just do it, it's not too hard, everyone else is doing it. How long will this take you? Just come, almost putting pressure, some demands, and the protective nature, which is the other extreme, where the parent, the teacher, the therapist might try to encourage, almost like try to rescue the child, skip school, let's give you a delay, let's give you extra time, it's too hard for you. And the problem with each of these, and the way that we'll address it, is without acceptance, without the demanding nature almost increases the risk of a lack of validation, a lack of acceptance. And it's really important for the child to sense that you understand their internal experiences, because internal experiences are hard to verbalize. And they'll be skeptical about your recommendations. They'll be skeptical in their minds. The risk of, let's say, touching the doorknob, the risk of committing to a certain course, the risk of, there are so many examples I could use, the risk of raising their hands and giving a guess in class, those risks are almost as terrifying for them as asking you to drive the wrong way on a highway. And we want to really acknowledge that it makes sense that they're scared, and it's not their fault. This is a disorder. This is something that they didn't cause, you didn't cause. This is something that is emerging. It's making them have a difficult time. And we need confidence. We need to express confidence. We need the child to believe that and sense that you believe that they can handle this hard thing, this hard activity. So acceptance is about, it makes sense that you're scared, and confidence is about, and I believe you can cope without running away, without avoidance, without compulsions. So we're going to work on crafting supportive statements to really help the child sense that it makes sense you're scared, and I believe you can do this hard thing. So I think I'm going to skip this. You can take a look. This is just a quick exercise if we had time, but I'm not sure if we have time to understand. Some of these statements are supportive. Actually, we could just look at this. Some of them were acceptance geared. Some of them were more confidence focused. Some of them neither. And then there was one that was both, which is ideal. So it's hard and you can do it. Acceptance would be something like, I get it, it's not easy, anxiety is uncomfortable. Confidence is you can power through it, but we don't want to only have confidence. We can combine this. Anxiety is uncomfortable, and I believe you can power through. And neither, it's all in your mind. You can't be thinking about this. And unfortunately, some of these things are often stated. Responding to reassurance-seeking behaviors also falls under this expressing confidence and compassion, because essentially what's happening is, like we talked about, the obsession might be, I need to know, I need to get this right. I'm terrified of the failure. What if I don't do well? And they're asking you, is this safe? Or will I get sick if I touch this? Or is this correct? Did I say something weird in that social activity? Was I normal? So how to respond to reassurance-seeking behaviors is all about agreeing with the fear, because like we talked about, OCD in particular, also anxiety, is somewhat about the difficulty with tolerating the unknown. And unfortunately, despite our best efforts, the feared outcome might occur. We don't know if they think that you're weird, and we want you to be able to tolerate it. We want them to be able to tolerate that possibility, essentially. So I'm going to respond to reassurance-seeking behaviors with the supportive statements that we just talked about on the previous slides. So I know this is scary. That's the acceptance element. And I also know you can handle it. I don't have a better answer for you. I don't know which class to pick. I don't know what to wear. I don't know what you should wear. I'm not 14 anymore. And you're gonna make the best decision that you have. And this is a more lengthy answer, but I just want to show a variety here, because I want you to develop things that are consistent with your style. The feeling of not knowing is so uncomfortable. I get it. Of course you want to know. And I'm confident in your abilities to make a decision with the information that you have. So far we talked about labeling the exact fear non-judgmentally. We talked about crafting supportive statements and reducing reassurance. And now we're going to talk about modeling. So it's important to model calm, non-anxious behavior. So if someone says, if a child is asking me, is it okay, I forgot to say bless you after someone sneezed, true case, I won't provide more details though for confidentiality. Is it okay? And almost like running down the stairs, I don't know if I said bless you to that person sneeze. I don't want to amplify their concern. I want to have, and I don't want to judge them by saying, are you crazy? This is what you're thinking about? Don't worry, because don't worry is a form of reassurance. I might say, I don't know if you did. I don't know. I don't have a better answer for you. So calm, non-anxious behavior and tolerating uncertainty. If someone's really stressed that they fail the test, especially if you didn't get back the test yet, which is so common too with anxiety disorders, to almost try to prepare oneself for that worst case scenario. What do you mean you failed? You left the whole thing blank? So, okay, I guess we'll have to see, is what we want to model. So, especially, like I said, if we didn't get that test back. Using skills is the U in Lemur. And this is, using skills is important for the person, the parent, teacher, caregiver in this situation. And also I want to, I guess, like give a very broad general rule for helping the child use skills. So we didn't talk so much. I mean, I talked briefly about exposure and response prevention skills, how that's important. Sometimes mindfulness skills we'll be able to use personally because, like I said, accommodations often happen when we're distressed, when we know it's not ideal. And of course, in the moment, we sense that child's urgency. If we care about that child, we want to relieve that distress. So it's really important to consider what's needed for the child to be more successful and what's needed for me to be more successful, rather than thinking, what do I do now? Help. Rather than almost like what's needed to be less upset. So we want to focus a lot on what's needed most, consistent with my long-term goals, rather than what's needed right now. And along similar lines, we want to think about what would the child be doing if their anxiety or OCD wasn't as intense, if their anxiety or OCD wasn't present at all, what would they be doing instead? And try to encourage them to fake their normal self. But this is also about us here, because you're going to have to use the skills so that you are able to stay mindful in terms of like what's needed the most right now in order for the child to be most successful. Lastly, reinforcement, reinforcing brave behavior. This is so hard. Again, I really want to like validate that for some of this, oftentimes if fear is really intense, which anxiety can be intense and severe, it really feels like that they're risking death. They're risking, it's almost like I said, like driving on the wrong side of a highway. If I don't check this pimple out, this pimple that I'm preoccupied about really might cause the serious infection. It might lead to my death. It's so much easier to monitor it excessively, to maybe what we call body scan, rather than engage in the much harder thing to do. So we want to reinforce brave behavior. And even if the child's older, definitely specific praise works for any age, but sometimes recently even like a teenager asked me, we're working on skin picking, which is often a co-occurring problem with OCD. And the person was like, I think I want to do points and just get a Starbucks drink every week if I'm able to resist skin picking, which is, it's funny. I oftentimes don't recommend, not purposely, I almost forget about things like points for older teenagers, but they're powerful. We want to acknowledge the positive learning. We want to acknowledge a phrase that I often use is, when you did this, so I felt very proud of you. So that way I'm just making sure that I'm very specific. When you talk to that stranger, when you talk to that new person that for the first time at their house, I was so proud of you. And sometimes I even add, and it motivated me. I remembered how brave you were, and I was able to do XYZ hard thing. So reinforcing brave behavior, sometimes with younger kids, things like token economies, you'll see what works, different point systems like we talked about, where points can earn things. And let's review the Lemur model here. And as we're reviewing, I again want to acknowledge that I know that this is almost like a marathon. This is almost a marathon of a presentation. We're reviewing a lot. And think about almost like what we would ask of the children that we're working with. Think about your strengths and weaknesses in terms of the Lemur skills, in terms of labeling, and which areas could you use more improvement, which areas do you feel you do well in, and thinking about maybe focusing on one skill at a time. So first, labeling in as much specificity as possible, the child's anxious or perfectionistic or OCD, I guess, feelings and beliefs. The next skill we talked about a lot about supportive statements, how to express empathy and compassion without looking to immediately reduce the behavior, modeling calm, non-anxious behavior, and using skills. And that's where we were talking about just what does the child need to be more successful instead of what does the child need to be less upset. Sometimes, hopefully, it could be the same thing, but oftentimes the immediate relief of distress is often a compulsion. And rewarding brave behavior is the last. And oftentimes, as we wrap up presentations, I just feel a need to acknowledge that this feels dense to me, and I hope I didn't overwhelm you with content the last 50 minutes. And I want you to remind yourself what motivated you to join today. Were you just being nice to me? Or was there, to what extent is this a worthwhile investment for you? Thinking about the kids that you engage with. Obviously, this is, it requires a lot of effort and practice to learn new things, which is why I want you to think about 3 takeaways from tonight. Definitely new skills that require effort and practice to implement, and it's possibly one of the best gifts you can give children, the gift to be able to handle overwhelming feelings, the gift of being able to approach difficult emotions, do hard things, essentially. And let's review, even though we sort of reviewed the Lemur model. So we talked a lot about labeling the exact fear and belief non-judgmentally. We talked about how anxiety and OCD disorders might manifest themselves in the classroom across age groups. We talked about providing supportive statements, the acceptance. I understand how hard this is. It makes sense it's so hard, and I believe you could do it. So we're looking to reduce the accommodation and modeling, motivating, and prompting the use of effective skills. How can you fake your normal self, even though this is really on your mind? I really get that it's on your minds. How can you essentially act as if you didn't have this anxiety or obsession right now? And agreeing with the fear. We talked about reducing reassurance because unfortunately, despite our best efforts, failing can occur. And because anxiety and OCD is oftentimes about intolerance of the doubt, intolerance of an overestimation of risk, underestimating the coping, we want to really approach the possibility. It's possible that, is it possible or probable? And hopefully if the fear is possible, but not probable, we want to be able to agree. I know it's possible. How would we handle that? And the feeling is so hard. How can you try to approach it gradually? This quote I often put, we must see the child as in trouble, not the cause of trouble. Here are great resources, Trails to Wellness, Anxiety in the Classroom. You have the slides, so I'm not going to review this and the next one out loud. Book recommendations and some references, and I am happy to take questions if there are.
Thank you so much, Devora. That presentation was absolutely phenomenal. And I'm definitely ready to shoot into some questions. So first we had a comment. Someone said it is helpful to have examples of what to say to encourage.
Okay, sure. So I would really start with a supportive statement. And if the person wants to even bring up an example that is occurring in their setting, that's totally fine. What's an example that's coming to mind? I don't know why a phobia is coming to mind, but that might not be as relevant. Let's do like someone's procrastinating studying or doing their work because they feel overwhelmed by the volume, the quantity. So I might start with the acceptance and confidence piece. I know you really do have a lot. You have 4 tests and in specificity because we want them to realize that we really get it. You have 4 tests, you have 2 quizzes, and I believe that you could do it. How could we start? So not focusing on the all or nothing element to it, really focusing on what would you be doing if you didn't have all of that on your mind. How would you be starting? I hope that's helpful. Happy if you want to follow up with that, that's fine.
So another question that we have is, how do you help your child with anxiety if you also struggle with it?
Yeah, that's hard. And definitely, I think the Lemur model can be helpful in being able to recognize what the other person's, what your child's anxiety is eliciting, in you. And definitely there are good treatments. If you are interested in pursuing, exposure and response prevention has a really high effectiveness rate of over 70%. And it's a really great gift. I do believe oftentimes that it's helpful to remove the shame and guilt oftentimes the parents with anxiety is feeling like they're causing their child's difficulties, and the research and the way that we think about it's not a helpful thought, but we also find that in many cases, I mean, there often is a genetic component, and the more that a parent is able to work on their own, it is possible and very likely that the child will get better. So I would say focus on your own first.
And another one that we have is, how would a therapist deal with a child who is stubborn in their avoidance? What phraseology or strategies can be used to get the child to be more open-minded about facing their anxieties?
Okay. Yeah, it's hard because you're never going to be able to force someone to do something. So I oftentimes would really try to understand the child's values. In what ways is their anxiety or OCD interfering or robbing them of their life worth living, in terms of, I don't know, if it's any social activities that they're fearful of missing, or I mean, there's an infinite of examples. I don't know why I focus on that one, but really focusing on in which ways their anxiety is taking away from their valued activities. But also it's possible that incentives would help. That may have been tried, I acknowledge that. And oftentimes more gradual exposures can be very helpful. So it's possible that when exposures aren't working, and I know there might be a problem of willingness here, we often think about, can we approach this more gradually, and are we really targeting the feared outcome appropriately? So I would start there, and good luck. It's hard.
Another question that we have is, you mentioned that OCD is often correlated with values or even religion. How do you teach a patient to avoid compulsions when they have strict religious rituals?
Yeah. And there is actually a great OCD group that focuses on based OCD, and we never violate religious activities. So oftentimes it's really important to really, with all OCD, we're working on disengaging from the content, because it's not about the content. It's really about that fear of unknown. So we're going to focus on, let's say it's the fear of whether or not I'm going to go to hell. So we're going to focus on that. We're really not violating religious activities. And it's really important to collaborate with a trusted religious individual to help the person identify what is OCD and how someone without OCD would engage in that particular religious activity.
Thank you. And another question that we have is, my son has Tourette syndrome, ADHD, and anxiety. He often goes to the bathroom during class time. He only has a 504 plan. The school is struggling with trying to set up a plan to avoid this. He is not a behavior, it is not a behavior issue, so they allow it. I don't like it.
It's tricky to understand without more detail. I'd be curious to understand what the child is doing in the bathroom. If he actually needs the bathroom, is this a medical situation? Is this more of an avoidance? And if it's an avoidance, trying to understand what is the child avoiding. The questioner is correct in that we're careful when providing a child with accommodations, because we don't want them to rely on, we want them to be able to handle their anxiety. And oftentimes, probably in the past month, I did sign letters encouraging or recommending 504 and IEP plans. So when they are used, we do recommend frequent revisiting. So we don't want them to be permanent accommodations, and perhaps a more, I guess, a titrated plan to help the child approach these activities that he may be avoiding while being in the bathroom. That could be helpful.
And so that the same person said that their child that they're just avoiding, and it's because of their Tourette's.
Okay. Yeah.
So I guess they're going to the bathroom to be able to let it out, and I guess just
right.
not have
Okay.
the anxiety of being in the class.
It's often embarrassing. I don't know exactly what this person's experience is, but many people would describe how embarrassing it is and how they do feel like they need a break. And I would be mindful of helping the child try to get back into the classroom with the use of competing responses. If the child has tried CBIT therapy, cognitive behavioral intervention for tics, that could be helpful. And best of luck. I'm happy to follow up if you want to share more details.
And just from my own personal, she says, thank you. From my own personal experience, I know that a lot of the times, especially in school, I know I would go into the bathroom to let out my tics, and I would literally come out of the bathroom like out of breath. It would seem like I ran like a mile, but that was for me where I would let them out. But I think that what you're saying is 100% correct. And if this individual does want more information or wants to contact you, I can definitely give them your contact information. And
qualified providers with tics, hopefully. It's often very treatable.
And so that is the last question that we have. It is currently 8:32, so we're going to start wrapping up. Devora, thank you so much. Okay, so thank you for joining our webinar tonight on identifying and supporting anxiety and OCD in the classroom. An archive recording of tonight's webinar will be posted to our website, www.njcts.org, under the heading Programs. The webinar blog is now open and accessible underneath the archived webinar. It will remain open for the next 7 days for any additional questions that were not covered this evening. We will be back in September with a whole new look and feel to our webinars. We are so excited for you to see what we have in store, so make sure to tune in. This ends tonight's webinar. Thank you again, Dr. Scher, so much for your presentation, and thank you everyone for attending. We hope you have a wonderful night.
Thank you. Thank you, Katie. Thank you, everyone. Good night.